Post-renal transplant ureteric stricture, RGP and stenting for those cases. Patient undergoing renal transplant sometimes can have ureteric stricture for various reasons like PK virus, ischemic, technical factors, and all these cases sometimes require stenting and it can be very difficult. As we can see here, this is the normal cystoscopy, but usually the neo-ureter will be way high on the dome. The angulation here is not very good, as you can see here, and becomes very challenging to stent these cases, and many a times we have to do antegrade stenting for all these cases. So what we can do is, in such cases, empty the bladder completely. Once we empty the bladder completely, most of the time the ureteric orifice come on the floor, and just like a normal ureteric orifice, we can cannulate it with a guide wire and sometimes a J-tip angled guide wire, and we can do it very easily. In case that is not successful, then we can turn our scope upside down, as we can see here, and then empty the bladder partially. We can see the orifice, angulate that ureteric catheter onto the neo-ureterostomy, and with the help of either a angle tip guide wire or with the help of a straight tip Teramo guide wire, we can cannulate it. Once cannulation is there, again we can bring the scope in the normal position and we can stent such cases. All this measure fails, then we have option of doing antegrade stenting under ultrasound guided. You can see the RGP here. This patient is having lower ureteric stricture, have undergone transplant almost 4 years back, and now the stricture have developed. The creatinine was steadily rising. We have done the stenting for this patient. The creatinine came down very well. The plan is to remove the stent, wait. If the creatinine is again rising, then she will need native ureter piloureterostomy in due course of time. Thank you.